Welcome to tape 2 in our series on chiropractic myofascial release. On tape 1, we went over some basic principles regarding working with the myofascial system. We also discussed principles of altered biomechanics, and we learned some specific techniques for correcting various postural distortions in the pelvis and also in the thigh. On tape 2, we're going to begin by learning how to correct various postural problems, biomechanical distortions in the lower leg and in the foot. We're going to start first with the tibialis anterior in the anterior compartment of the lower leg. The anterior tibialis, of course, will start actually on the undersurface of the foot. It's going to go through the flexor retinacular tissues and up along the shaft of the tibia. Reasons for treating this could be possibly, well, typically are symptomatic reasons. Shin splints, also hammer toes and bunions, not so much because of the anterior tibialis itself, but because of two small tendons that lie next to it. There's a groove in between the anterior tibialis and the lateral peroneal muscles, specifically the extensor hallucis longus and the extensor digitorum longus, which of course attach to the big toe and the other four digits in the foot. If they happen to be shortened, we can end up with the bunion deformation in the foot. I'm going to start palpating the anterior tibialis, actually not on the undersurface of the foot, which we'll get to later, but distal to the flexor retinacular tissues, about 1 inch to 2 inches beneath that. Now right here I find some resistance. Since the muscles of dorsiflexor of the foot, I'll have the patient go from dorsiflexion to plantar flexion at 1 inch per second. Of course, I'm palpating towards the heart. I find the resistance, and the patient's going to lengthen the muscle against the resistance of my thumb. And I'm using a covered thumb contact, of course. As soon as I feel a release, whether I actually hear or feel a crackling sensation as the scar tissue breaks up, or I actually feel like a saltwater taffy stretching sensation, then I'm going to move upward. I find a piece of resistance there. I go beneath the lesion, ask the patient to go into a dorsiflex position, slowly into plantar flexion. Now I could cover the thumb with my pisiform. I could even use knuckles. Whatever works for you is what you want to do. We'll do this typically 3 to 5 times per spot. Relax. I'm going to work all the way up the tibialis anterior, actually going lateral to medial now into the shaft of the tibia. Since fascia binds most commonly against the bony prominence, you're likely to find a lot of lesions here which could be affecting sensations in the feet. A lot of times burning sensations in the feet, cold, lower extremities can be helped greatly by working this muscle, actually working all the superficial tissues in the lower leg. Go ahead again. Now we're going to continue working up the leg in this fashion all the way through the shaft of the tibia. Make sure you have the lateral to medial line of drive. When I get closer to the knee, to get a little more of a stretch, I'm going to have the patient still dorsiflex to plantar flex, but also go from slight knee flexion to knee extension. So for instance, if maybe 3 inches distal to the tibial tuberosity, I find some restriction. Relax. Like as I do there, I'm going to place my thumb beneath it. I'll bring her into slight knee flexion and dorsiflexion of the ankle, and then I'm going to ask her to move into the corrective postures. And then you want to straighten your knee. Just like that. And that gives us a little more of a stretch. And we can work all the way up into the knee. If we want to work the rest of the belly of the tibialis anterior, I simply move out about half an inch to 1 inch lateral from the shaft of the tibia. Again, I start distal to the more disjointed self. When I find a restriction right there, I'm going to simply have her go from dorsi to plantar flexion. Okay. Sometimes I'll assist and have the patient just relax as I do it passively, especially if the patient's older and is having trouble perhaps coordinating his motions, or in a child. When I get up into the belly, and if I feel resistance as I do right here, again, the same motion. A little more force though, because we're dealing with a larger portion of the muscle. And then I would repeat that 2 or 3 times. And again, as I get to the more proximal portion of the muscle, the patient's going to also add a knee flexion to knee extension, as well as ankle dorsiflexion to ankle plantar flexion. Perfect. We'll do that again. And one more time. Of course, you always want to go back and check your work. Never assume that you made the correction. Always go back and see if there's anywhere from 1/4 to 1/2 of an inch of fascial drag. The next muscle I want to work on will be the peroneal muscles, or the lateral compartment of the lower leg. But beforehand, you want to prepare that, the work you're going to do there by treating the tendons in between these two groups of muscles. Also, if the patient happened to have the bunion deformation or hamartose, a lot of times pain can be relieved. It's associated with this by releasing tension within these tendons. Sometimes you can actually see the groove I'm referring to. If you can't, and it's kind of hard to see it on our model here, what you'll do is you'll find the medial aspect of the lateral malleolus. So here's the lateral malleolus. I'll just find the medial-most portion where I bang into the talus, and I go superior to it, and I'm in that groove. I feel for resistance. It's common to find a lot of problems here. I find some right there. The patient, again, goes from dorsiflexion to plantar flexion. I use a covered thumb contact. I typically use thumb on thumb or pisiform on thumb, just like that. And we want to work all the way into that groove. You can actually feel it, even though we can't see it, and you work all the way through. If we get an area where there are varicosities, we want to work around it, but not through that area. Okay, next I'll ask the patient to lie on her side. Okay. To work the perineal muscles, the basic motion will be dorsiflexion to plantar flexion, but more importantly, eversion of the calcaneus to inversion of the calcaneus. So we'll have one leg behind the other, so she can do this more easily. Now we're going to start the work, not quite the undersurface of the foot, but very close to it. The pronatus longus has an attachment which goes behind the styloid process of the fifth metatarsal, and then it attaches all the way on the medial aspect into the insertion of tibialis anterior along the apex of the arch. So I'm going to palpate behind the styloid process, feel for resistance. Now, with external rotation problems of the foot, this is going to be a muscle that has to be worked on along with the tensor fasciolatum, gluteus minimus and medius, and the piriformis. If she has a history of ankle sprains and has pain related to that, as an after effect, this is also a muscle that can be helped symptomatically. So I start palpating behind the styloid process. In this area, it's hard for her active motion of eversion to inversion of the calcaneus to really be effective. So I'll passively do this on the patient. I'll take her into as much eversion as I can get, and then I'm going to invert her. If I have her do this actively, because I'm pushing in the same direction, I lose my contact. So this is a portion where we definitely want to do it passively. Let the patient just relax. Sometimes this is a little sensitive. Dr. Ida Rolfe used to say that once you stabilize the pelvis, which is one of the first things we want to accomplish in our work biomechanically with patients, she would add that you want to next put a healthy pair of feet under the pelvis, since the feet in the ambulatory position are, in a very real sense, is the base of our spine. Okay, now let's begin to loosen up. And I've now reached the lateral malleolus. At this point, I'm going to work along the shaft of the fibula and then posterior to the shaft of the fibula to get the three portions of the pronatus muscles. There's a lesion right there, and here I can actually have our patient, since I'm actually on the malleolus, begin to actively do the motion from dorsiflexion to plantar flexion and eversion to inversion. So Claudette, if you'll go ahead and do that, and then lengthen the muscle. Excellent. And then again, you want to get a little more inversion, bring that. Okay. One more time. First we want to see the inversion, which will look to be more like that. Okay. Then we're going to work up the shaft of the fibula. You can see the added motion we've got now. If we had a problem, for instance, with the common peroneal nerve and entrapment causing a tarsal tunnel problem, or if we had burning sensations in the feet or lack of vascularity, releasing this fascia is going to have a tremendous impact on improving that situation. As I go up the shaft of the fibula, again, I'm muscle on bone, or tendon on bone. So it's common to find a lot of restrictions, as we're finding a large area here. When I get an area of an inch or two of restriction, rather than doing a lot of thumb motions, I'll take a broader contact. In this case, I'm going to use several metacarpal phalangeal joints. I'll lean in and I'll ask the patient to do those two motions. Dorsiflexion to plantar flexion, eversion to inversion. And again. Just like that. Excellent. Getting a nice release there one more time, please. Good. Good release there. Now we hit our next area of resistance. And again, let's see how much we have. We have one right there. It moves fine. So it's a small one. I'll use a thumb in a small area. Thumb backed by piezoform contact. And go ahead, Claudette, and do the same motion. Make sure you actually, before the patient performs a motion, that you show them how it's done. Obviously, we can't say go from dorsiflexion to plantar flexion for the average layperson and expect them to know what we're talking about. Okay, got a nice release there. I come back and check that. And we got extra motion. And I'll, of course, check all the way up to the superior portion of the fibula. And then I'll do the very same thing posterior to the fibula, where we find a tremendous amount of dysfunction, especially in the case of a sprained ankle, where as a result we get a lot of scarification in the area. I feel some scar tissue here, 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 here. It's like, where don't I feel it? Actually, it goes probably about 5 inches. So I'll take a real long thumb contact in this area and ask Claudette to go perform the motions that's necessary. Okay, lengthen slowly, a little slower. Good, and again. Okay. Now recheck, getting good release here. Be cautious in this area, the common peroneal nerve is here. You're not going to damage it by working on it in a longitudinal fashion, but you still want to be a little gentle. Okay. We have a hunk of scar tissue here and here and here. I'll use a broader contact. Again, I'm sliding actually through the scar tissue, so my thumb, this portion, will be placed over probably a good inch of that scar tissue. And I'll cover it now with my piezoform, and I'll ask the patient to perform that motion. There we go. And again. And of course, I'll work all the way up along the posterior shaft of the fibula. I'll next have the patient lie in a prone or a face-down position. In this case, I'll work on her left side, and I'm going to work the posterior compartment of the lower leg. A real important part of the human body that work. There are a tremendous number of muscles here that cover a lot of symptoms and also can cause partial distortions. One problem we deal with, a lot of times when a person has a problem with hyperpronation, what we'll find is that because we're hyperpronating, the navicular bone oftentimes will subluxate in an inferior manner and has to be replaced or pushed upward. We'll be covering that in the next section of this tape. Also, because the navicular bone is being pushed downward each time the person steps on a solid surface, the plantar fascia gets pulled and gets irritated, so plantar fasciitis can easily develop. Because of the attachment of the plantar fascia along the medial tubercle, the anterior calcaneus, we can end up developing heel spurs there. I want to start with a brief discussion of heel spurs. Heel spurs typically are calcified tissue and not ossified tissue. That being the case, we can work right through, directly through the tissue, the calcific tissue, and break up heel spurs usually between 5 and 7 visits, especially if we're combining it with water ultrasound, or ultrasound and water. The way we're going to do that is I'll first release the tension in the plantar fascia with the patient going from exactly plantar flexion to dorsiflexion as I work towards the heart. So I'll start the ball of the feet and have her actively move in plantar flexion. This can be exquisitely sensitive. We'll keep doing that. Especially along the apex of the arch, we find attachments again of the tibialis anterior and the peroneus longus. So you want to be a little more sensitive here, but at the same time you want to really ferret out any of the scar tissue that may exist there and treat it thoroughly but more gently. When I get to the anterior aspect of the calcaneus, the medial portion, of course, is right here. You're going to dig deep if you suspect or have been told that the patient has a heel spur. And I feel the tubercle right there. There's no heel spur there, but there's a tubercle. And if there was a heel spur, I'm going to go distal to it, which in this case is closer to her toes. She's going to go from plantar flexion to dorsiflexion as I press right up into the tubercle. And again, I could ultrasound the patient's foot in water, of course increasing the dosage that we're using to compensate for the fact that we're treating her in water. Once I've accomplished that, the next thing I want to do would be to work the Achilles tendon. If she has a history of Achilles tendonitis, she's ever injured the Achilles tendon, what I'm going to do will be 2 techniques. One technique involves going lateral to medial directly into the lateral aspect of the Achilles tendon, and then also medial to lateral. On this foot, how it would look, I'm going to take a contact and press lateral to medial with one hand, and then medial to lateral with the other. I'm pressing though inward at the same time, as the patient goes from plantar flexion to dorsiflexion. Go ahead and plantar flex. Now, if the patient has an acute injury, acute damage, go ahead and acute damage to the Achilles tendon, that would be a contraindication for doing this at that time. I would do everything possible to quickly transition her into a subacute stage so I can effectively perform fascial release on this area. And I would do this 3 to 5 times, and then I'm going to switch to a direct P to A contact using a broad thumb contact on the posterior portion of the Achilles tendon, just like that. Now I'm going to actually, go ahead and do that, dorsiflex. Now as you can see, I have very little authority over my contact, and as a result, she's pulling my thumb along with her. So I want to go ahead and use a covered thumb contact, get a little more force over what I'm treating, and have her go into dorsiflexion. And again. Okay. Now the next area I want to work would be the gastrocnemius muscles, and I'm going to work centrally, I'm going to work laterally, and of course I'm going to treat the heads right here. What I'll do, I usually use a fist contact if I find a restriction. This is the muscle gets beat up a lot, being an anti-gravity muscle. We got a restriction there. We're doing fine. We're doing fine. As I come up to the attachments, we got a problem there. Is that tendon right there?
Yes.
Okay. And right
Yes.
there. Okay. The lower portion, I'll treat strictly with the patient moving from plantar to dorsiflexion. Go ahead. And I'm pressing at a 45-degree angle, I to S, P to A. No lateral to medial component. I'm going to do this a third time. Okay. And again, I want to check and make sure I've increased movement of the fascial tissues, and I have. When I come up here, maybe slide that just a tiny bit. Good. When I come up to the lateral head of the gastrocnemius, the patient will be still going from plantar flexion to dorsiflexion, but primarily is going to be going from knee flexion to knee extension. I'm going to make a double thumb contact and then ask the patient to go ahead and straighten the leg. Just like that. And that can be done several times. Do it again. Okay. Now we can do the same thing along the medial aspect, and then when we're done that, we'll try to go deep to the now loosened gastrocnemius muscle to treat the soleus. The way the soleus is treated, I use a knuckle contact or thumb contact, and I just drop actually anterior to the gastrocnemius muscle bilaterally. So I'm going to be pressing approximately in this area. Now the soleus here is really a mess, and I'm finding a lot of lesions. Actually up here is fine, but down in this area lower, it's stuck for quite a substantial amount of area. So I'm going to slide and get as broad a contact as possible, and I'm going to ask the patient to go from plantar flexion to dorsiflexion, just like that. And again. Okay, at the conclusion of that, when I've done it on both sides, on this side it would look something like this. I'm then going to displace the gastroc and the soleus as far medialward as possible so I can get specifically on the posterior aspect of the fibula where I can treat the flexor muscles, the flexor digitorum longus and extensor and flexor hallucis longus. The patient will still do the same motion, plantar to dorsiflexion, but make sure the muscles have been released enough so you can now treat not the sleeve, but the core or the deep intrinsic muscles of the lower leg. So I'm going to push now the gastroc and soleus medially, you can relax still, and I'm going to palpate along the shaft of the fibula. Don't be surprised if you find that the entire fibula is just filled with scar tissue, as it seems to be here. Usually it's sensitive. Scar tissue, remember, is more sensitive to pressure. Okay, we're going to go ahead and ask the patient to now plantar to dorsiflex. That's a good rate of motion right there. I'm going to take one hand away so you can see that more clearly how it's being performed. Okay. I would treat all the way up a little higher. I'll show you how this would look. I'm going to displace the tissue again, palpate, find a lesion, cover thumb contact, and the patient's going to go from plantar to dorsiflexion. Now at some point, keep going, at some point, and again, you're going to have to arbitrarily decide where knee flexion to knee extension is going to come in. Usually I just divide the leg into two zones. And when I get up higher, perhaps in this area here, where actually I don't find resistance, I would have the patient still do the ankle motion, but at the same time perform some knee motion as well, just to get a little more force and stretch into those tissues. Switching over to this leg momentarily, if I wanted to treat the medial aspect of these deep intrinsic muscles, specifically tibialis posterior, I'll laterally displace the gastroc and the soleus muscle. This is an important technique to do for club foot, where we have an infant whose foot is held in a internally rotated and inverted and also a plantar flex position. It's also real important for deep posterior shin splints. We're going to displace the tissues laterally and treat directly I to S and P to A on the shaft of the tibia. Now, there's a lot here to treat, a tremendous amount. Actually, every area here needs to be treated. I'll displace the fibers laterally, and I'm going to ask the patient to go from plantar to dorsiflexion. The principle remains the same. I would do it 3 to 5 times. When I get up closer into the knee area, again, I have to just relax the patient, dorsiflex the tissues involved. I'm going to get right on the shaft of the tibia as the patient now does some knee extension and also some dorsiflexion, just like that. I want you also to straighten your leg out. Perfect. Okay. One word of warning when you're treating shin splints: if you have a patient who has severe shin splints and there's a history of foot burning or numbness in the foot, perhaps there's been some trauma in the area, and as you're examining the patient, the pain's getting worse, and you may notice there's some shiny or discoloration or redness in the area, that more than likely would be a case of anterior compartment syndrome, which is a medical emergency requiring a call to 911. We're going to next move on to treatment of the foot. Next, we're going to demonstrate 3 corrections for the foot that relate to hyperpronation and external rotation of the foot. The first correction will be treating the mortise joint in between the tibia and the talus, which tends to get compressed more on the medial side when the person's undergoing this type of postural distortion. As you note, I'm on my knees, the patient's straight-legged, and they're facing me. I'll take a contact that's going to look like this. It's a thumb backing a crooked index finger, which is going to be placed directly into the mortise joint, which runs obliquely between the malleoli, or underneath the malleoli. So I'm going to go ahead and press A to P, take an I to S tissue pull. I'm going to then use another thumb in contact behind the first thumb, and I'm going to ask the patient slowly at the rate of 1 inch per second to do a half squat. Now, even if they had bad knees, a half squat's not going to substantially stress the knees, so it's just safe to do. And then relax. Since the problem typically is on the medial aspect, mostly I work right here, pressing slightly medial to lateral on the medial aspect of the mortise joint. Okay, and I'll come back. If I'm working with someone who doesn't necessarily have pronation or doesn't have external rotation of the foot, I may go ahead and if they're a runner, for instance, or a basketball player doing a lot of compressive activity into the ankle, I may actually work more A to P and more lateral to medial and do the same technique. I'm going to have the patient turn around directly. And now I'm going to treat the talocalcaneal joint, which tends to get compressed, also in the medial aspect with the external rotated foot and the hyperpronated foot. Here we have 2 depressions on each side of the calcaneus. I'll take a crooked index finger and I'll place one into the lateral depression, one into the medial depression, this depression right here. I'm going to hold the heel down. Now, as I hold the calcaneus down and the patient goes into a half squat, what will happen is the calcaneus wants to travel with the talus. I'm now going to hold the calcaneus down and stretch the fascia and the scar tissue which may exist between the 2 bones. So I now press and I ask the patient slowly to do a calf squat, and then we do it again. The first couple times I stay in the same area. I may go up a little higher subsequent times just to really fully treat this area. Then lastly, and probably the most important routine, which has to be by necessity done after you do the first 2 foot corrections and you've done the leg work, is to have the patient assume a fencer stance, and we're going to do what's known as a navicular lift. Have your foot put it out there. Okay. Now the patient in a moment is going to be asked to assume a standing posture, fully bearing their weight on your crooked index finger backed by a fist. It's almost as if you're shooting a gun, that kind of contact. I exaggerate the arch, which probably is lost on this side. I place my finger underneath the arch, backed by my other hand. What's going to happen, this is now a fulcrum, don't move yet. This is a fulcrum against which she's going to flatten her foot. Of course, when she does that, the navicular bone is now going to be forced in a superior and lateral manner, typically subluxates medialward and inferiorward. So go ahead and very slowly straighten your contact. Okay. You might put a hand on my shoulder. Can you do that?
Oh, I can push it.
Okay. Bear your weight. A lot of times you'll actually get a clicking sensation as the navicular bone begins to go back into its position and relax. Under normal biomechanical circumstances, this medial column here should not just be placed lateral to medial to the lateral one. It should actually be cantilevered on top of it. So using the navicular as our fulcrum point, you can actually hopefully lift it up. Each time you do this, you want to take a new tissue pull that's a little deeper and also a little more superiorward. Do this again. A little more towards me. There we go. Patient likes to move away because it's a little on the sensitive side to have this performed. But the correction doesn't have to be done very many times, usually 2 or 3 times, and you got a nice long-lasting correction. And that completes the footwork. Next, we're going to address the issue of altered biomechanics and postural distortion in the upper extremities. Things we need to consider would be high shoulder, low shoulder, internally rotated shoulders, and also the retracted scapula. In the case of a high shoulder, for instance, if we had it on the right side, we want to be concerned with treating ipsilaterally the levator scapula muscle, the upper trapezius, the SCM, the scalenes, the supraspinatus, and also the origins of the splenius, capitis, and cervicis muscles in the T1, T2 area back here. Well, on the low shoulder side, we want to concern ourselves with treating the muscles that could pull the shoulder down, such as the pectoralis major and minor, the serratus anterior on the side, the subscapularis, and the infraspinatus posteriorly. The first technique we'll do now will be the levator scapula, which we do in 3 portions. We start off by treating the origin of the muscle, which we could also treat symptomatically for stiffness of the neck. We take the upper trapezius and we displace the fibers medially so we can specifically get on the transverse processes of C4, C3, and C2. We get on the transverse processes and we pull up, feeling for restriction, which I find on that side. This muscle also obviously can be involved with head tilt as well as the elevated shoulder. I find a lesion at C4, I take a covered finger contact at C5, I push P to A and I to S as I bring her head from extension to flexion to the opposite side. As you notice, I'm not dragging my fingers upward. They lock into the area of fascial resistance and they're going to induce fascial drag. 3 to 5 stretches per area of restriction. Of course, I can lubricate this area too to make it a bit more comfortable for the patient. Next, I'll have the patient for the same muscle lie in a face down or prone position. And we're going to now treat the insertion on the medial superior border of the scapula. With her arm to the side, I'll ask the patient to shrug her shoulder. I'm going to be pressing S to I on the insertion if I find restriction, which I find right there. There's no motion here, whereas here you can see quite a bit of motion. So I press S to I into the lesion, covered thumb contact, and I ask the patient slowly to lower her shoulder as I press S to I with the scar tissue, entrapping it and breaking it up as I have her go through this motion. We'd repeat it again. This is a common area of significant fascial restriction. It's probably one of the most common in the body and really should be paid keen attention to. The last portion of this technique involves her putting her arm behind her back I'm going to ask her to shrug her shoulders up towards her ear. What I'm attempting to do now is I'm going to take my thigh and I'm going to place it behind her behind her forearm. You can relax now. Keeping her shoulder in an elevated position. The reason we want the shoulder elevated is because we want to actually be able to go anterior to the scap. We're not going to be aiming merely for the supraspinatus tissues. We're going to try to get in front of the trapezius and in front of the scapula and work the anterior attachments of both levator scapula and the omohyoid, which lies directly lateral to it. Many times when a person's had a hyperflexion injury, they'll tear the anterior attachments, and forever afterwards they'll complain of deep nagging posterior shoulder pain, which usually can be remedied by 2 or 3 treatments in this manner. So again, she shrugs her shoulder towards her ears. I stabilize, tightly stabilize the shoulder in this position. You can relax. I take a finger contact and I go anterior to the medial superior border. I push up and there's a little tubercle against which the anterior attachment of levator scap attaches. Right next to it, my middle finger will be on the omohyoid. I'm pulling superiorward, feeling for fascial drag. If it's not there, I pull up in a A to P fashion, and I ask the patient to bring their shoulder down against the resistance that my leg offers it, so they move very slowly. Because of the invasiveness of this, we only have the patient do this 1 pass per treatment session. The next 2 muscles we want to treat for the high shoulder will be the ipsilateral upper trapezius and supraspinatus. The upper trapezius technique involves treating the medial superior border of the scapula, which we can also use as a substitute treatment for the insertion of levator scapula. Also treating the spine of the scapula, and then of course the belly of the muscle. The line of drive will always be S to I in this case. This can also be slightly P to A. I palpate downward, feeling for any restriction. I find some right here. I only find this one. I'll take a open fist contact, nice relaxed contact. I ask the patient to turn their head away and lean their head into my hand, and then as I apply it downward, S to I pressure, to tuck their chin to the opposite shoulder. That's done 3 to 5 times. I'll also palpate S to I on the spine of the scapula, an area of common entrapment of fascia in this area. This whole area along the spine of the scapula is covered with some degree of scar tissue, so I'll take a very broad contact, and again, ask the patient to turn their head away, bring their head back in towards my hand, and tuck the chin in towards the opposite shoulder. And again, this one will need a little more treatment, probably closer to 5 passes because of the great degree of scarring that's occurred here. And one more time. Okay. And then for the belly, it's the same procedure. We palpate medial to lateral now, as well as S to I. And I find most of the restriction in this case right here. I may take a more specific knuckle contact. If it was broader, I could even use an elbow contact like this. Right, let's demonstrate that move. Let's have you bring your head towards me and tuck your chin to your opposite shoulder. And I just relax as she moves away. I could do the open fist contact as well. Bring your head into my hand and tuck your chin away to the opposite shoulder. The supraspinatus technique involves 2 parts. We'll be treating the belly of the supraspinatus and also the portion where the tendon goes under the acromion process to attach anteriorly against the tubercles in the front of the humerus. I'll be palpating again S to I, more specifically on the supraspinatus muscle. If I find a lesion, whether it's here or in this little triangular area where the tendon inserts or dives deep to the acromion process, I'll be using a smaller contact as the patient goes from shoulder abduction to adduction, abduction to adduction, just like that. The patient, again, brings their arm out to the side of their body and then brings it closer to the side of their body. When I treat the area where the tendon dives under the acromion process, it's a very small area. I take 1 knuckle. If there is a restriction, and there really isn't here, but if there was, I would take a knuckle contact and ask the patient again to go from shoulder abduction to shoulder adduction as I very specifically press down S to I in this fashion. Let's do that again. My actual contact will be a covered hand contact like this. Okay. And that completes the supraspinatus technique. Next, we'll do the SCM muscle, which we not only do for the high shoulder on the ipsilateral side, but we can also do it obviously for a head forward posture bilaterally. We can do it for ipsilateral side bending or contralateral rotation. This is a very complex muscle. Symptomatically, we can treat this muscle for upper molar pain, ear pain or fullness, ringing in the ears, dizziness, vertigo, of course torticollis, and a history of hyperextension injury. There's 4 parts to the muscle routine. The first part, the head is turned towards the side of treatment as we're treating the belly of the muscle, immediately distal to its attachment on the mastoid process, down to where the muscle bifurcates at C4, C5. We grasp the belly of the muscle, and don't be bashful about grasping it. You really need to get in there using pincer palpation and grasp the muscle between your thumb and index finger. You're pulling downward, feeling for a drag, and there is some right there, at which point, while I maintain my grasping contact, I'll ask the patient to turn their head to the opposite side slowly and look up. So they're going into contralateral rotation and also extension. You want to bring your head up like that. Perfect. Okay, we'll do that usually 2 to 3 times, not quite as many times as other muscles. I'll go further down with the head turned towards the same side. There's some restriction there as well. And again, the patient, as I apply an S to I pull going this way, will rotate the head away and then up into extension. Extend your neck. Good. And relax. Now we'll do that a couple more times. And that's about where it bifurcates, and it feels good there. The second and third parts consist of treating the sternal attachment. If you'll push your head in my hand, push your head in my hand right here. There we go. You can see the sternal attachment. I just palpate S to I and see if there's any restriction, which there is. I'm also, in the third part, going to do the same thing to the clavicular attachment, and there's a lot of restriction here as well. So I'll take a covered thumb contact, just like this, and ask the patient, as I push S to I, to turn her head away and up again, same as the previous portion of the technique. And of course, I'll actually cover my contact like that. Let's try that again. And I'm pushing the fascia downward, but of course the whole time I would actually be using a pisiform on a thumb contact. You want to have your fingers flexed so they're not out towards the chest. The last portion involves the patient turning their head from the contralateral side to the ipsilateral side. It also involves the doctor repositioning himself or herself to take a thumb back by a crooked index finger contact. And you're going to palpate I to S, feeling for any restriction in the origin against the mastoid process. It's feeling good right there. You can see there's good motion there. Right here, it's stuck. So I'll take a contact and go directly lateral to medial and I to S underneath that area of scar tissue. And I'll ask the patient to turn her head into the same side. Same side, turn towards me. And she turns towards me, and we'll repeat that 2 or 3 times. Let's do that again. Now that was just with one thumb. Usually I'll get in there and I'm going to block the contact and hold like this. 2 times to 3 times is usually sufficient. The patient need not rotate their head any further to the point where their nose is pointing up towards the ceiling, and that completes the SCM technique. Next, we're going to treat the origins of the splenius capitis and cervicis, which insert in the spinous areas from T1 to T4. The important area is right around T1, T2, where we have a sympathetic ganglion coming out of this part of the spine. With a head forward posture or an elevated shoulder, as this muscle becomes hypertrophic, it can entrap the sympathetic ganglion, and the person can then suffer henceforth from sympathectonia, which essentially is a condition where they have elevated blood pressure, shallower and more frequent respiration, cold clammy hands, frequent colds, harder to get over colds. So we want to treat this area. Also, it's involved with a head forward posture. It's involved also with Dowger's hump and the elevated shoulder. The way we're going to treat this is I'm going to make a little indentation posterior to the transverse processes of the cervical spine, but anterior to the upper trapezius. To relax the upper trapezius, I'm going to ask the patient to let her head just rest against my hand. And you can see the indentation forming. It's imperative that we don't press lateral to medial into the brachial plexus. So we want to be behind the TVPs, which are here, but in front of the upper trapezius. I go as deep as I possibly can. Sometimes I'll even hold static pressure for 10 or 20 seconds, letting the area relax. And then once I feel like I'm on an area where there's no downward drag, I stabilize my contact and then ask her to rotate her head away and tuck her chin to the opposite shoulder. Now you'll see as she does that and gives me room, I'll go ahead and put a piezoform on my thumb. Let's do that again, and this time about twice as slow. Usually this is only done one time, maybe 2 times at the most. So again, I'm behind the transverse processes in front of the upper trapezius. Go ahead and rotate your head away. And tuck your chin into opposite shoulder. And then I get in there and I really stabilize it where we need to. And that completes that particular technique. Before we begin our treatment of the muscles involved with the low shoulder, I want to say a word about the treatment of the scalene muscles, which sometimes are involved in a high shoulder. However, my experience is that typically when the scalenes shorten, rather than causing a high shoulder, they merely cause an elevated first rib, which is significant, and we'll save the treatment of that for our discussion of neck muscles. Right now we're going to begin our treatment of muscles that cause a low shoulder, and we'll start with the pectoralis major and minor. The pec muscles, in addition to being involved with a high shoulder, are also involved with the treatment of an internally rotated shoulder, as well as pseudoangina when the pectoralis sternalis is involved, thoracic outlet syndrome when the costoclavicular area is involved, and also painful swollen breast tissues when the pectoralis costalis is involved. So we're going to be doing this in 3 parts. The pec clavicular, we palpate actually I to S and lateral to medial and A to P, but directly underneath and into the clavicle. So I palpate like this, and if I feel resistance, as I do here, I'll take a covered contact and ask the patient to go from adduction to abduction very slowly, 3 to 5 times. Just like that. And my contact, as you notice, is right, pressing I to S right into the clavicle. I can also, by the way, drop an inch inferior and just press strictly A to P and do the same routine for the subclavius, which also sometimes is involved with thoracic outlet syndrome. When I'm treating the pec sternalis, I'll ask the patient, if it's a female, to take the knife edge of her opposite hand and displace her breast tissue. So I'll just ask the patient to use the knife edge of her hand and displace her breast tissue that way during the actual treatment. So you can see what I'm doing. I won't have her do that now. And I'll be palpating on the costochondral junctions, feeling for any scarring, any resistance to a medialward displacement of tissues. Right here I feel a little bit, so I'll take a knuckle contact just to get real specific. It's a very gentle contact actually, and I'm going to have the patient go again from adduction to abduction. So just bring your arm, this arm across your chest and then outward. A little slower. Do it again. About 1 inch per second. About 1 inch per second. A little faster. Okay. And then we'll move on after 3 to 5 passes to the pec costalis. The pec costalis addition can also be involved with fibrocystic disease. We're going to be palpating a lateral to medial line of drive. If it feels resistant, and again we would have the patient displace breast tissue accordingly. If it feels resistant, which it does right about here, I typically use an open fist contact and have the patient lift their arm up. However, there's going to be more of a superiorward component to it as I push also a little more inferiorly with my contact. And again. And you may do that 3 to 5 times. The pectoralis minor, which is also involved with thoracic outlet syndrome, as the neurovascular bundle tries to travel in front of it, and behind it and in front of the coracoid process, we can treat by finding the coracoid process. We find the greater tuberosity, we find the bicipital groove, we find the lesser tuberosity and then the coracoid process. I'm going to go underneath it and press I to S, also lateral to medial into it, and medial to lateral, feeling for resistance. I feel some resistance mostly when I go lateral to medial and I to S. I'm going to press contact like this as the patient lifts her arm up. You can also do this passively, which I'm going to choose to do here. I'll take a knuckle contact to get very specifically lateral to medial and I to S and A to P against the coracoid process as I bring the patient's arm up into abduction, just like this. And again, you can see my contact. I'm using a lot of mass, but I'm not using a lot of force. It's really a pretty gentle contact as I do that 3 to 5 times. The next muscle that we'll treat for the low shoulder will be the serratus anterior, which can also be used to treat side stitches in athletes who run a lot, and will be treated in the following manner. We'll be palpating from rib 2 to rib 9, including the portion under the scapula, in an A to P and lateral to medial orientation. If we find any restriction, which we do right here, we can use an open fist contact, we can use a covered thumb contact. I'll use an open fist contact here. The patient will be instructed to move from a protracted shoulder to a retracted shoulder position, as if they're doing a reverse punch. Okay, go ahead and move. And we'll do that several times. Do it one more time. Okay. If I was working in the actual subscapular region, for instance up here, it's usually a smaller area we're treating. I would probably use a covered thumb contact. Again, the patient will move from shoulder protraction to shoulder retraction. Move your shoulder back, please. Okay. And that's how we treat the serratus anterior. Next, we'll do the subscapularis technique, which again is for treating a low shoulder. It's also used for treating an internally rotated shoulder, and it's also used for treating a host of symptoms ranging from popping and clicking in the shoulder, weakness of the shoulder, as well as superior shoulder pain. I reach underneath the scapula with the patient in an abducted position. My thumbs are above the scapula, and I attempt to palpate lateral to medial, but most significantly anterior to posteriorly, actually on the anterior surface of the scapula. Now she's restricted quite a bit in here, which you expect to find in someone with a history of swimming sports, especially freestyle swimming, bench pressing, and throwing sports. In fact, usually if I have a patient who has that history and has any shoulder pain, I want to at least attempt to find a reason for releasing this muscle. Here's some significant restrictions here. Once I found them, the patient goes from internal rotation and adduction to external rotation and abduction of the shoulder. And we'll do this 3 to 5 times. And continue to do that, please. Now initially, you'll only be able to get on the lateralmost aspect of the scapula. You want to at least be that deep. If you're not deep enough, you'll be merely on the latissimus dorsi or the teres tissues. As this muscle releases, you're able to get even deeper and go more medialward. The infraspinatus muscle is not only involved with the low shoulder, but it's also the muscle most commonly involved with deep and or anterior shoulder pain. So for any of those 3 reasons, we can do this technique. We're going to be palpating lateral to medial across the infraspinatus muscle, including underneath the spine of the scapula by going I to S underneath it. If we find any restriction in a medialward direction, as we do right there, we'll make a nice open fist contact as the patient goes from external rotation to internal rotation of the shoulder, as in this fashion here. We'll do that usually 3 to 5 times. Frequently when you're doing this, the patient will report a duplication of the symptoms if their chief complaint was anterior or deep shoulder pain. The anterior deltoid muscle is sometimes, although rarely involved with a low shoulder, more commonly it's involved with internal rotation of the shoulder along with its partners, the infraspinatus and the subscapularis. It's also the most common cause of dull, diffuse shoulder pain, where the patient complains of pain throughout the shoulder but can't really pinpoint it to either the superior or the anterior aspect. We're going to palpate from the anterior tubercle, the deltoid tubercle of the humerus to the lateral edge of the acromion, this area in here, and also in the lateral 1/3 of the clavicle. If I find any restriction, as I do right there, I'm going to have the patient's arm move from flexion to extension. There could also be a slight abduction to adduction component. This technique is actually performed in a passive manner, so I'm going to do all the motion for the patient. As I use an open fist contact, I press lateral to medial and I to S as I bring the patient from a short into a lengthened position. I do that several times. If I were to find a lesion up by the acromion process, the technique would look pretty much the same. I'm using an open fist contact as I bring her from flexion to extension and moderate abduction to adduction. And if I found a lesion underneath the lateral third of the clavicle, which we actually should have gotten with the PEC technique, and we find a lesion right there, I'll press A to P and then hook I to S underneath the clavicle. Now here I won't use a very large contact point. It's pretty specific, and it's my thumb. And I'll bring her from almost pure flexion of the shoulder to extension several times, treating this muscle thoroughly. The next muscle we'll treat will be the rhomboid major and minor muscles, which run obliquely from the inferior aspect of the scapula into the spinous processes and finish running from the medial superior border of the scap to C7 in this lower cervical spine. It's involved with a retracted scapula. When you're doing a postural analysis from the P to A mid-sagittal plane and you see one scapula closer to the spine than the other scapula, you want to release it by stretching out the fascia overlying the rhomboid tissues. Also, if the patient had deep pernicious mid-back pain, meaning they had persistent mid-back pain that didn't remit with thoracic manipulation, we'd want to go ahead and treat this muscle as well. Bear in mind, however, that the anterior cervical discs, after a hyperextension injury, can actually refer pain along the medial aspect of the scapular borders. And the way we differentially diagnose what's causing the problem is if the person has thoracic lesions, obviously we palpate and adjust those. We can also have the patient squeeze their shoulder blades together for 10 seconds. That's a Travell rhomboid cramp test. And relax. If the patient reports a duplication or an exacerbation of their symptoms, we'll go ahead and do the following technique. If that doesn't remit, the pain doesn't remit, and they have a history of hyperextension injury, we may want to refer them for an MRI to see if there is damage to the anterior annular fibers. The patient's motion will be shoulder retraction to shoulder protraction, as if they're throwing a punch. Go ahead and do that. It'll be slow, again about 1 inch per second. My contact will be, after I've located the lesion, palpating lateral to medial and S to I in this oblique fashion. Once I find a lesion, as I do right here, I can take a covered thumb contact, or more typically an open fist contact, as the patient performs the punch-like motion from shoulder retraction to shoulder protraction. And we've done it several times. However, when it's done in reality, it will look a little more like this with a covered hand contact. And that completes the rhomboid technique. Next, we'll treat the triceps muscle, which we're going to treat not for a postural problem, but more for symptomatic reasons. If a person complains of deep elbow pain, two muscles I want to consider would be the insertion of the triceps and also the anconeus. We'll treat the anconeus first, which runs from the olecranon process to the lateral epicondyle in a small triangular fashion. This is an area of common abuse. If we find a problem there, which I do right here, we'll stabilize distal to the lesion, double thumb contact, and the patient will slowly, 1 inch per second, move from elbow flexion to elbow elbow extension rather, to elbow flexion. We'll do that again. I'll take my stabilizing contact hand away so you can see more specifically the line of drive moving I to S and P to A. Okay. When we're doing the triceps, we go right above the olecranon process. Now, if she had olecranon bursitis, we can treat through the bursitic condition and help her. We have 3 heads here, so we want to make sure we go lateral, central, and medial. As I go more laterally and get the lateral tendon insertion, it's stuck, and I'll have her, again, go from extension of the elbow to flexion. And I would do that several times. This is a common area of problem, and it will alter the way the elbow functions and lead commonly to elbow pain and sometimes even wrist pain. We can palpate up through the bellies, however, rarely will you find a lot of scarring there. Where you will find scarring will be the attachment of the long head of the triceps into the lateral superior margin of the scapula. I find some restriction here, and here, and here, and then it moves fine here. So we have a significant area of entrapment. So I'm going to go ahead and use a covered thumb contact, or I could use an open fist contact as the patient goes from flexion of the, or rather extension of the shoulder to flexion of the shoulder. And I'm pressing lateral to medial, but mostly I to S and P to A. Try that again. And I'll do it once without the stabilizing hand so you can see specifically how I'm working with my thumb. The brachioradialis muscle and the intrinsic muscles underlying it are often involved with tennis elbow. To treat this, it's a very simple procedure and usually will cause a complete remission of symptoms within 3 to 5 treatments. We'll find the brachioradialis belly itself, which isn't usually the more problematic muscle, but we'll check for it anyway. And Claudette does have some problems actually throughout the muscle, so we're going to go ahead and palpate I to S and lateral to medial as the patient goes from elbow flexion to extension. You can also assist in this as well and have the patient do it more in a passive manner as you move them through this range of motion. I'll take my other hand away so you can see specifically how I'm working. And I continue to move superiorly about every 3 to 5 passes until eventually I work up to about half of an inch proximal to the cubital crease. I also like to displace the brachioradialis fibers medially and get on the real important intrinsic muscles, namely the extensor carpi radialis, longus, and brevis, and feel for lesions, which are usually abundant, and do the same routine. Go ahead and here I have the patient move more actively so we can really get a good stretch on the fascia here in the muscle and its scar tissue. Here's how it's done without the contact, stabilizing it. And again. Bear in mind that tennis elbows usually involves a clinical triad consisting of the muscle dysfunction here, P to A olecranon, or P to A elbow fixation, and then also distal radius fixation, and usually some hypermobility in this area. And that should all be treated to get successful results with treating tennis elbow. Most of you realize that the surgical success rate for carpal tunnel syndrome is very poor, approximately 1 to 2%. The reason why the success rate is so poor is because typically surgeons and even people in the field of manual medicine are looking only at the carpal tunnel for the site of involvement. When we do our tests such as Tinel's test and Phelan's test, the symptoms are produced in the carpal tunnel and we assume the problem is there. We want to add a functional test for this, which will tell us if anywhere along the course of the median nerve the neurological tissues are compromised. And this will be the opponent's pollicis longus test, where the thumb and the small finger approximate one another, and we're going to attempt to pull the fingers apart against the patient's resistance in a neutral, a hyperflexed, a hyperextended, a radially and ulnarly deviated position, as well as pronation and supination. If any of those are weak, the next thing we'll do will be to move on to palpating the course of the median nerve where we're suspecting that the median nerve may be entrapped by scar tissue within the forearm and the upper arm and even the shoulder girdle. If I feel any lesions, which I do right here in the flexor retinaculum, I'll go distal to the lesion as the patient then moves from flexion of the wrist to extension. And I'm using a double thumb contact here. I'll do 3 to 5 passes. Usually if the patient's real symptomatic, I will use a slight lubricant with them. The anterior interosseous membrane is above the retinacular tissues, and it's not uncommon to find lesions there, which would be treated with a flexion of the wrist to wrist extension position. When you get up into the pronator teres area, which according to numerous research studies is the most common site of entrapment of the median nerve, the patient will go from pronation and flexion of the elbow to extension and supination of the elbow. Okay, you go ahead and extend and supinate. Just like that. Do that several times. This area may have 5 or 6 areas of scar tissue which feel a lot like a BB or a Rice Krispie underneath the skin. One more time. And then we'll treat, after that, the area of the ligament of Struthers. To get to it, you need to displace the biceps muscle. You're pressing directly on the distal shaft of the humerus, and if you found a lesion, the patient would move strictly from elbow flexion to elbow extension. Usually you won't find much above that, except the subscapularis is often involved, and we would just do the subscapularis routine as we taught earlier. It's imperative that the person eats a diet that's rich in vitamin B6 and also does the following exercise. I'll ask Claudette to take her hand, and I want you to hyperextend the wrist, and I want you to pull it towards the opposite hip. So you're going to pull it towards your left hip. And she's going to hold it 3 times 6 seconds. She will do that every waking hour, 3 times 6 seconds, every waking hour until she's symptom-free, which should approximately occur within 3 to 10 treatments. And that completes our portion on the extremities.